Morning, colleagues in the room with us here at ACMS and colleagues online. I'm Jo Beery from the African Centre for Migration and Society here at WITS, and co-hosting this with my colleague Langa, who will introduce herself a bit later when we get to the discussion. This is the second in a series of seminars or webinars around migration, health and wellbeing in context. And this is a partnership between two global health research groups funded by the National Institute for Health and Care Research in the UK, GEMS and Nurture for Youth, with the ACMS and the Arua Guild Cluster of Research Excellence in Migration and Health. We're also doing this in collaboration with the School of Social Sciences, and are delighted that Prof. Lorena Nunes, who is head of the school, is going to be kicking us off with some discussion. So today we're going to be talking about cities in motion and looking at the connections and disconnections between health, violence and crisis in South Africa's urban worlds. We hope today to facilitate a conversation that will look at the intersecting and multi-level dynamics of migration and urbanisation and the way in which they impact population health and well-being. Central to current debates, as we're all aware, is the need to focus on structural as well as interpersonal violence, including that promoted by anti-foreigner vigilante groups that remain defining features of life in many urban settings. We seek to move beyond abstract policy debates by grounding discussion in real, tangible experiences and challenges, while also highlighting pathways that might lead to inclusive, more inclusive, equitable and health-promoting urban futures. Today, we're delighted to be joined by a wonderful group of panelists. We have Diego Iturralde, who is the Chief Director for Demography and Population Statistics at Statistics SA. We have Dr. Silindile Malilo, who is Coordinator of Xenowatch, here at the ACMS, and you'll hear a bit more about that program when she does her input. We also have Dr. Rebecca Walker, who is part of Collective Voices, which she will share, which is a civil society and NGO network looking at issues around xenophobia in access to healthcare in South Africa, and Becky's also part of ACMS. We are then going to hear from Dr. Federica Duca, who is part of the Johannesburg Crisis Working Group here at WITS, as well as part of PARI. And then, as I mentioned, we will be kicking off our discussion with Lorena from the School of Social Sciences. So without further ado, I'm going to hand over to Diego. Morning, Diego.
Morning.
Hi, thanks so much for joining us. Just let me know when you'd like me to move the slides for you. Just let me know and we'll move forward from here.
Okay, perfect. We can move on to the first slide then, and the one after that. Okay, well, good morning, everybody. Thank you so much to ACMS for this session and for inviting me to it. I've been tasked to set the scene for this morning's conversation, and I think the brief that Jo gave me was to provide a background in terms of migration trends, but also to focus on issues around urbanization and on how all of this intersects with health and public health indicators. So I've attempted to do that. And I think a good place to start is to start off with who are we and how many are we in terms of the 2025 mid-year population estimates released in July this year. We estimated that the population in South Africa stands at 63.1 million persons. Next slide, please. Of these, more than half, almost 60% of this population lives in just 3 provinces where we know the major urban centers lie. Next slide. If we have a look at how population change is composed, we can start off by looking at where we started in 2024, which was at 62.3 million. we had about 1.12 million births. And I think the story about births is an interesting one, because we are beginning to see the confirmation of the beginning of a fertility decline in South Africa, similar to what we have been seeing in other parts of the world. Added to that, we have a positive net migration of about 210,000 persons, and then we have around 560,000 deaths during this period of mid-24 to mid-25. And this brings us to our total of 63.1 million for July of 2025. Next slide, please. Right, if we have a look at population growth is made up of natural increase, that's the difference between births and deaths, as well as net migration. And we see this over time has been oscillating. Prior to COVID, it was roughly standing at about 800,000 persons, or if my memory serves me right, around 1.5, 1.6% per annum. And then with COVID, that obviously dropped quite significantly, and there has been a recovery, but it has not yet reached the levels that we saw prior to COVID. And we can see that the impact of net migration is as profound as on natural increase, in that net migration patterns are still on the recovery, as is natural increase. Next slide, please. Okay, so when we perform population estimates, we obviously compile a series of assumptions, which are all empirically based. And for our international migration, our net international migration assumptions, which are from a mid-year to a mid-year for a 5-year period, we can see that compared to previous 5-year periods, the estimated net migration for 2021 to 2026 stands at 870,000 persons. I just showed you in the previous slide that for one of the years it was 210,000. And of course, that 1 year was a strong year in terms of recovery. The 21 to 22 and maybe 22 to 23 would have been a lot weaker because of the recovery period, or the period within the pandemic that we were experiencing at that time. Next slide, please. So migration is many things, as we all know. Many local government authorities will maybe say that it is a burden on their fiscus. Other people may say that it's a security risk. But I think we are all very familiar with a lot of the literature around migration, that it is a developmental phenomena, and it is a phenomena that helps people seek new opportunities when those opportunities are required. One of the things that we often do not consider is that for provinces that are losing population, international migration creates a buffer against that. So if we have a look at provinces like the Eastern Cape, Limpopo, the Free State, and to a lesser extent the Northern Cape, had it not been for those international migrants, those populations would have been a lot smaller. Of course, we need to weigh this up against other provinces which are already experiencing a positive net growth, and where international migrants are contributing to that positive net growth. Next slide, please. Okay, this slide and the next slide are just slides showing the migration flows from a province of origin in the previous 5-year, or at the beginning of the current 5-year period, to the province of Gauteng. We see that most people moving to Gauteng are coming from outside South Africa and Limpopo. You can see those are the two thickest streams. If we have a look at the left-hand side where the place of origin is. And if you go to the next slide, we will see Western Cape. Oops, one back to the Western Cape. And there we can see that we have, as a place of origin, the Eastern Cape, Gauteng, and outside South Africa are the main places of origin for people moving to the Western Cape for the period 21 to 26. Next slide, please. So population estimates are not the only place in which we measure migration. Of course, we have recently had a population census, and this is the fourth population census that we've had in a democratic dispensation here in South Africa. And I think what this slide is indicating to us is that for international migrants, as shown in the previous slides, Western Cape and Gauteng are the preferred places of residence. If we see how this has evolved over time in the Western Cape, from the 2001 census onward, it has increased from 10.5% to 15.6%, whereas for Gauteng, from 46.5% to just over 50%, which is actually a little bit of a decline from what we had in 2011. I think we should also consider that at the time of the 2022 census, many of us were working from home, and there was a lot of semigration. Many people from Gauteng were moving to other parts of the country, and so that decline in Gauteng and the increase in the Western Cape may have something to do with the practice of semigration that we saw at that time. Next slide, please. In terms of places of origin, the makeup of where migrants have come from has changed quite dramatically. If we have a look at 2001, I can count three European countries: Portugal, Germany, and the United Kingdom. If we then move to 2022, I think it's only the United Kingdom that remains. We see that Zimbabwe and Mozambique are consistently in the top two, although the order changed between 01 and 11, and that Lesotho has become a significant contributor to international migration in South Africa. Next slide, please. In terms of internal migration, and I think when we talk about urbanization, I think our focus now shifts from international migration to internal migration, and the age structure of these people is significantly different. So if we have a look at the orange bars, the ones that are not shaded, that is the age structure for people who have not moved for the period between. It's for this is on lifetime migration. So this is from the time of birth up to the time of census. So these are people who live in the province where they were born, and we can see it's quite a normal looking population pyramid with a broad base and a youth bulge in the middle and tapering off at the top. However, if we look at the gray bars, these are lifetime migrants. So these are people who have moved from where they were born, from the province where they were born to where they are at the moment. And we can see here that the base is much narrower, so fewer young people, shall we say, children who are involved in that. But young adults are most certainly the predominant group that are involved in this movement, and then it too tapers off. Another feature is the feminization of migration. If we had this conversation 10, maybe 15 years ago, migration would have been highly male dominated, but we see that females are moving as much, according to this population pyramid, as males are. Next slide, please. Okay, these next few slides are just a few maps that have a look at the geographical distribution of internal migration. Here we see that in the Western Cape and in Gauteng that the proportion of the population who have migrated into those respective provinces is 19.8 and 34.4% respectively. And of course, this is coming from a high base. These are the two most populated provinces in the country. And so it's a finding that we would expect to see. Next slide. This one looks at out-migration, similar story. In the case of Gauteng, large population in this province. So it stands to reason that those who are leaving the province, whether for elsewhere in the country or out of the country, is quite high. But what stands out here now is that the Eastern Cape and KZN and even Limpopo show higher levels of out-migration from this province compared to the Western Cape. Next slide. And here we're looking at females. This is also just looking at females who came into a province. These were females born outside the province and now residing in these provinces. And I think this represents the population growth in those provinces. And the next one is for males, which tells a similar story. All right, next slide. If we ask ourselves the question, where are people moving to and from? I think we can see that the Limpopo to Gauteng stream is the most populous one, around 10.6 and 11% of females and 11% of males who engage in internal migration are migrating along these routes. And then other routes would include the Eastern Cape to Western Cape and the KZN to Gauteng route. Next slide. If we look at these corridors, the corridors are just a sum of routes in both directions. Here we see what we confirmed in the previous slide. Male dominant in the Gauteng, Limpopo and KZN Gauteng, slightly female dominant when we look at the Western Cape to Eastern Cape. And so there certainly are some dynamics in that Western Cape, Eastern Cape corridor when it comes to female migration. Next slide. If we have a look at the reasons for migration, I know that the text here is quite small here, even for me. But I think that when we ask questions around reasons for migration, we usually ask for what is the main reason, which can be a bit limiting because you may have many reasons why you have moved. And I think going forward, we will be changing this question to ask people to highlight their three main reasons. And I think the main reason are work-related. So we can see the top two reasons are looking for paid work or a job transfer or moving to live closer to a relative. So with the top two reasons being work-related, we can see the importance of the labor market in terms of internal migration movements. And that is 100% why Gauteng and the Western Cape maybe attract as many migrants as they do. Next slide. And related to that, and I think Jo was indicating in her introduction around vigilante groups, if we have a look here at the proportion of employed immigrants by industry for 2012, 17, and 22, we can see here that where immigrants are employed is reflected in this graph with all the different sectors, different industries in which international migrants find themselves in. Next slide. Right, I'm familiar with the concept note that was shared with everyone before this meeting, so I thought I should indicate on this slide an updated version of what was in that concept note. And I think what's important to see here is that this is the province of residence on the rows by province of birth along the columns. What is important to look here is to see that the total inflows into any given province, if we look at Gauteng, for example, 4,026,000, is significantly higher for internal migration than it is for international migration, which is at 1.2 million. If we add the inflows into Gauteng and the outflows from Gauteng, which are that 1,062,000, then we can see that the internal migration turnover for Gauteng is at just over 5 million, and for the entire country at 16.7 million. So we are talking about 16.7 million internal migrants compared to 2.4 international migrants. Certainly international migration more important from a policy perspective, but in terms of service delivery, in terms of outcomes of how and when people receive services and the quality of those services, internal migration is a far more significant subject to look into. Next slide. Just a few more slides here. In this one here, we're looking at migration flows. So I think we all know the difference between stocks and flows. These are persons who have moved between 2011 and 22, crossed a provincial border, and moved into one of the metros. The blue bars are for internal migration, the orange ones for international migration. We once again see what we've been talking about, movements into the city of Cape Town and into the 3 Gauteng metros far higher than any of the others, but also that in the internal migration across all metros is higher than that of internal migrants. Next slide. These are now migration stocks, so this is based on lifetime migration. So people who have crossed a province since they were born to the metro where they currently reside, and we see a similar pattern. Next slide. And this one is really a summary of the table that I showed you. These are province to province moves from a lifetime migration perspective. Once again, we see that across all provinces, the internal migration far stronger than the impact of international migration at a lifetime level. Next slide. Okay, and then this one is on the internal migrant turnover, which was the last column in that table, which I showed you, where we see that Gauteng is just over 5 million, and then we have Eastern Cape at around 2.2 million, and Limpopo in the Western Cape just under 2 million. The next slides and the last few slides have all to do more with public health indicators. And these indicators are national indicators. They are not migrant specific. And I think part of the challenge that we have is around the production of health indicators for migrants specifically, which through the ACMS, through partnerships with the Department of Health, we are looking forward to see if we can be able to, and we should be able to, disaggregate administrative data as well as survey data of public health indicators by migratory status. This graph here really shows the number of deaths per year and how they were impacted by the pandemic in 2021. We can see a dip there in life expectancy, which is the green line, and how the number of deaths that increased in 2021 has recovered somewhat all the way through to 2025. Of course, these are, once again, these are from population estimates, so they work on the basis of mid-year to mid-year. So the 557 you see for 2025 is for mid-24 to mid-25. Next slide. Now, if we look into that drop in life expectancy by males and females, we can see that both males and females had a approximately 3-year drop in life expectancy, which is remarkable. I mean, it's not something we've ever seen anywhere in the last 100 years, and how the recovery, which was driven through a evidence-based approach to fighting the pandemic, the development of vaccines, public health initiatives, have resulted in us actually now having recovered completely from the pandemic in terms of life expectancy, where life expectancy for males, for females, and for the total life expectancy has now recovered to beyond what it was before the pandemic. Next slide. If we break that down by province, not all provinces have experienced that similar recovery, though. We see that in the Free State, KZN, Northwest, Northern Cape, life expectancy is still lingering at below 60 years of age, whereas in the Western Cape, we are seeing life expectancy much closer to 70 years of age almost. Next slide. These two are just the under 5 mortality rate and the infant mortality rate. These have recovered significantly and remarkably well since the HIV pandemic in the early 2000s. We can see that this group showed high levels of resilience against the COVID pandemic. But of course, what's not present in this graph is, as I mentioned, the migratory status disaggregation. And we are aware that migrant mothers and migrant children are usually the ones who are left by the wayside or who are left behind when it comes to initiatives to improve and address issues of under 5 and infant mortality. Next slide. Of course, HIV, I've mentioned, is a significant health indicator. We can see here how the impact of ARTs have made a contribution to the fight against AIDS from 2006, where there's 673,000 deaths, which is almost as much as what we've seen in the first year of COVID. And of those, 275,000 were HIV related. We can see how the HIV related deaths have declined to around 80,000, even in a COVID pandemic year when people were maybe not able to receive their medication, etc. So once again, here, I think the success of the rollout program needs to be also viewed with a migratory status lens to ask ourselves the question: to what extent or how much have migrants benefited from this program too? Next slide. And it's the last slide. So let me thank you, all of you, for your attention. I'm sure I've exceeded my time limit. If you want to reach out to the migration desk or to myself, please feel free to use those email addresses. Thank you.
Thank you so much, Diego, and you were perfectly on time for helping us set the scene. And I think you've done a wonderful job in giving us lots of food for thought around the realities there. We're back. So I can pick it up again. Okay. So we're going to hand over to Silindile, who is from ZenoWatch. And in Silindile's inputs, we're going to be hearing a bit more about the work of ZenoWatch, but importantly, the work they've been doing recently, looking at the experiences of foreign nationals and access to healthcare in the context of the current vigilante violence that we are seeing. So Lindile, over to you. You've got 10 to 12 minutes. I'll let you know when you've got a couple of minutes left. Thank you so much.
Thanks, Joe. I hope I'm audible. I'm in a lobby, so I hope there won't be background noise. Hi, everyone. As Joe mentioned, I'm Slindile, and I am with the XenoWatch project at ACMS. So I will be looking at the issues of discrimination in the healthcare sector based on the research that we've conducted, as Joe mentioned. Next slide, please. So for those who may not be familiar with XenoWatch, just a bit of context. XenoWatch is a crowdsourcing platform which was developed by the African Center for Migration and Society, and we basically monitor and record incidents of xenophobic discrimination across South Africa. Initially, when we started, we're focusing on xenophobic violence, but we've since expanded to also include institutional and everyday discrimination, including denied access to services. So basically, the context in which I'll be speaking on, as Joe mentioned, following reports around denied access to healthcare in different parts of South Africa, but mainly we were getting reports in Johannesburg and Durban. We decided to conduct a research study to understand this in depth. We also did conducted verification processes in Witbank and Middlebank because we had also received numerous reports of migrants being denied access to healthcare. So for the purpose of this discussion, I'll be focusing on Johannesburg and Durban. I must say that the findings that I'll be discussing here are very preliminary. We've just concluded our data collection. So what I'm presenting is what we've been able to verify and validate. We are still also, beefing up our database, for lack of a better word, or adding more data in it because we're still following up on some incidents. So basically, South Africa's urban healthcare system, this appears through documentation barriers. So we've seen that migrants are being asked for, to prove their documentation to access basic care. Discretionary abuse, where vigilante groups such as Operation Tudula and March and March are taking the law into their own hands and also deciding who has the right to access healthcare. And then also we are seeing policy practice gaps where laws guarantee universal access, but implementation depends on local staff attitudes as well as such groups preventing migrants' access. Next slide, please. So all these issues are taking place in a context where migrants have to navigate fragmented bureaucracies, temporary permits, and constant surveillance, right? Health encounters have become microcosms of the urban border. Sorry, I hope you can hear me. There's a bit of background noise. Of urban border where inclusion and exclusions are performed daily. So to understand this better, as I said, we have been documenting incidents that reveal how the structural violence operates in practice. So to give you a bit of insights on the data that we've collected, I thought it would be interesting to highlight some of our findings from a report that was released in September, where we were looking at incidents of xenophobic discrimination between the period of 2022 to 2024. Next slide, please, Joe. Yes, thank you. So in our report, what we analyze is that because this was a second report that followed the 2020 and 2021 report. Basically, even though xenophobic violence has still remained as the most frequent incident type, with a slight increase in reported cases over time, we've begun to see that the nature of xenophobic discrimination is shifting beyond direct physical attacks towards systemic and economic forms. And in the 2022 to 2024 report, health xenophobia was one of the incidents that emerged as a growing trend in this reporting period. So while health xenophobia or health-related xenophobia falls under the broader categories such as denied services or denied access to services, we've decided to classify it as health xenophobia as it warrants its own category due to its pervasive and institutionalized nature of discrimination in the healthcare sector. So we've seen that the increase in incidents can also be associated to Operation Dudula, because since August 2022, there's been an increase in blocking of undocumented migrants from accessing healthcare. Some of you would remember the Kalafong incidents. I think that's when we saw visibly these vigilante groups taking action to actually physically block access. And also, we are also seeing that health xenophobia is also perpetuated by public officials and health staff. Next slide, please. So this is just like a visual representation of our data from, the report that was recently released. You'll see that health xenophobia, extortion, and harassment have, are some of the forms of xenophobic discrimination that have increased over time, whereas violence still remains as the most prominent form of xenophobic incident type. So next slide, please. I'll move on to our recent findings. Like I said, another disclaimer, these are still preliminary, but from what we've been able to analyze, the denial of access is mainly concentrated in inner cities and migrant-heavy suburbs, particularly in Joburg CBD, in the case of Joburg. We've also seen some form of gendered health exclusion where women face the highest rates of denial. And I must say, this is from the database that we've collected of victims who have come up, to report that they've been victims, as I mentioned. So women in the database, we see that women have the highest rates of denial, and most of these pertains to accessing services related to maternal and child healthcare cases, which, this is a form of structural gendered violence in a way. Issues of documentation access, even those with valid asylum permits or refugee documents that deny services. And this shows that policy implementation, not legality, drives exclusion. And also, I also must add that we were also receiving reports that some South Africans as well who could not prove documentation were also denied access to healthcare. And then there are issues of verbal and institutional abuse. Many reports include humiliation, refusal to touch patients, or being told to go back to your country, which is an indication of everyday xenophobic practices. Next slide, please. So, as I mentioned, this presentation is going to focus on Johannesburg and Durban. So basically in Johannesburg, most clinics affected show a concentration of xenophobia linked to denials. So a lot of these clinics included Uville, Helen Joseph, Hillbrow GP, Rosettenville. And then the nationalities that we were able to record, this is not a reflection of nationalities that have been affected overall, but the ones that we've been able to record in our database mostly were Congolese, Somali, and Zimbabwean migrants that were most impacted. And as I mentioned, the gender distribution, most of the participants were women. which also reinforces the gendered nature of healthcare exclusion. In the form of Durban, Addington Health facilities like the clinic and the hospital emerged as the epicenter of the healthcare issue related to xenophobia in Durban. And with the nationalities that were able to document, it was mostly those who were from the DRC, Burundi, Somali, and also we had some Ethiopians, and then the gender distribution as well. We're also seeing higher cases of women seeking maternal health care. And also, I also must give a disclaimer, is that we were also seeing that the ones that we were able to record as well were those who were mostly documented. Those who weren't documented were uncomfortable for obvious reasons, because obviously of their status. So they feared, issues of revealing themselves in case it might have implications for their stay in South Africa. So, in combining both findings from both provinces, like I said, Durban and Addington basically had most cases that were reported or that were able to document, while Johannesburg shows a more fragmented but systemic urban pattern across multiple inner city clinics. Across both cities, Congolese migrants were the ones that were able to document in terms of, so not necessarily facing the highest level of exclusion, but that we were the ones that were able to document within the study. Women are, as I mentioned, disproportionately represented, reflecting the feminization of vulnerability in access to care. Most cases reported, as I mentioned, involved those were documented. So that included asylum seekers and those with refugee status, and as I, and in some cases, even those, like, as it shows, even those with documentation, were denied access. And this shows that, which shows policy practice disjuncture. Those were also pending renewal or expired documents were often used as grounds for exclusion, especially in Durban. So the key takeaways so far from what we're seeing is that urban health xenophobia is especially concentrated in clinics that are serving migrant population neighborhoods. As I say, Durban's Addington is a complex, Durban's Addington complex is a systemic hotspot, whereas Johannesburg displays dispersed discrimination. And also that structural violence operates bureaucratically through ID checks, moral policing, and denial of maternal and chronic care. Gendered exclusion also shows intensifies vulnerability, especially among women and children. And also we see that documentation does not guarantee access, which exposes the fragility of legal protection and practice. So the research also reveals that health is a political frontier in that it is where citizenship is enacted through care or denial. So in conclusion, our work shows that health access is a lens through which we can understand the deeper architecture of exclusion in South African cities. And also, if we really want to build safer and more equitable urban futures, we must begin where life and vulnerability intersect, at the clinic door. Thank you so much for listening, and I'm happy to answer any questions. Thank you.
Thank you, Silindile, and that was perfectly on time. So thank you, you managed to get through a lot. And I think it's, whilst obviously it's a very unfortunate situation, I think it is exciting that XenoWatch is finding ways to capture and explore some of these more structural forms of violence in relation to healthcare access. So thank you for that. Brilliant. So I'm going to hand over now to Dr. Rebecca Walker, who is talking about work that has been undertaken by Collective Voices, and Becky's also based at the ACMS. So Becky, we'll hand over to you, and as you requested, I'll let you know when you're about halfway through.
Thanks, Jo. Just checking you can all hear me okay.
Yeah, that's great.
Perfect. So the fortunate thing about following Diego and Silindile is that they've said all the smart contextual stuff. So although I've got a few slides here that do provide more of the context to Collective Voices for Health Access, which I want to focus on, I'll try and go through these sort of fairly quickly, but I want to give a little bit more context. in terms of tying together these three interconnected dynamics of migration, urbanization, and health xenophobia, because it really sort of shows how and where collective voices for health access has kind of developed from, and kind of where the seeds were planted. So as the previous speakers have sort of have said, the urban health system has become a key site where national politics, service delivery failures, and these social tensions converge. And we know that health xenophobia is not an isolated issue. Issue caused by just individuals or vigilante groups alone. It's deeply structural, political, and embedded in governance crises as well. And I think key highlighting what was said in relation to XenoWatch is that documentation here has become the central gatekeeper of rights. So it represents, particularly in the case of Operation Dudula, which I'll mention a bit more in a minute, but it represents that really powerful mechanism through which rights and reality, the gap between rights and reality, is enforced. So you have access to healthcare, education, social services, welfare, all coming down to documentation, which in many ways reproduces the apartheid era logics of control. So it criminalizes mobility and entrenches marginalization for both migrants and for poor Black South Africans. And I think I'll start and end with this point that, a lot of the work of collective voices for health access is about finding that point of convergence between migrants and non-migrants and the shared challenges that exist. We can go to the next slide. Oh, no, go back. Sorry, I jumped ahead of myself. Okay, so we see, particularly in urban centres, how health facilities have become central to this focus. And I think what's distinctive here is that, you think of health facilities as safe as neutral spaces, and they've now become sort of sites of denial, surveillance, and violence. And this isn't accidental in any way. It's an institutionalized, both formally via policy, and we see that in a regression of policy, whilst the government talks about universal health access, as well as informally via everyday practices that violate the Constitution. So security reforms and vigilante mobilization come together and they help create this perception that migrants pose a threat to safety. And that's a narrative that's reproduced at both local and national levels. And we can go to the next slide. I'm not going to spend too long here, other than just to say that this is all happening within the context of the funding cuts, the ODA funding cuts, which have had a major disruption to the health system. And I think what's particularly key here, even though we know South Africa in relation to other countries has a relatively more robust health system, is the impact on the PEPFAR supported facilities for key populations, which were literally terminated overnight. And these were parallel systems that, thousands of migrants and citizens were accessing for the very reason that they can't access the mainstream health system. So now they've been forced back into into the systems that they're avoiding. And that, of course, has exacerbated and hastened this kind of focus on blaming migrants for overcrowding and challenges in the system. Okay, we can move on. So in many ways, xenophobia and exclusion has become normalized from the national level down and from the ground up as well. So we see government rhetoric increasingly framing migrants as the cause of systemic failure. And even when they condemn, acts by Dudula, or, they do speak out against it, at the same time, it's often a critique of their methods of blocking the clinics rather than actually the reasons why they're blocking the clinics. So in a way, it becomes this kind of feedback loop where leaders denounce attacks but echo claims that migrants overburden services. And this normalizes xenophobic narratives that is happening in policy and in practices, and basically emboldens vigilante actors who see their views reflected in official rhetoric, and intensifies public hostility. And I mean, there are many examples of those kind of comments made are regularly by, for example, Gayton McKenzie, the Sports, Art and Culture Minister, who wants removal of all illegal foreigners. But also the Health Minister and Parliamentary Chair have criticised actions by vigilante groups, whilst also saying, the health system can't cope with them. So, we see that kind of loop happening. And in the meantime, and as you can see on this slide, we see these kind of new policies and laws being proposed and coming into play, which show this regression that's happening while simultaneously the sort of overreaching language is around access for all. So it's kind of, this contradictory paradox that's happening. If we go on to the next slide, this is just wow. Okay. So I will pass over this very quickly because it literally just shows the regression of policies, and you can find this in papers that have been published. So you can go on to the next slide. So in terms of thinking about sort of civil society responses to health xenophobia, as I've said, health facilities have become these symbolic battlegrounds. And we have these populist organizations such as Operation Dodula, but there's also a more recent one called March on March, who have been, really garnering a lot of attention and being very effective in terms of blocking access to healthcare clinics, physically blocking access, whilst being able to sort of really support this claim that migrants are the cause of problems going on within the health system. And this kind of exclusion of migrants isn't new. There's been many sort of cases, and one of the key tactics or strategies that civil society has had to employ is litigation. It basically in order to get the government to actually follow its own laws. So, for example, Section 27 in 2022 challenged the denial of care to pregnant and lactating women and children under 6. And then recently we saw CAX, which is Copenhagen Africa against xenophobia, who are also part of the Collective Voices for Health, also took Dodula to the High Court, and the judgment basically said that Dodula should not be blocking access to healthcare. But I mean, even as yesterday, we were hearing about more cases happening in clinics around the Gauteng area. So the Collective Voices for Health kind of grew out of this recognition that there was fragmented responses from civil society. A lot of it was around litigation, but that activists and NGOs and migrant-led groups were also really struggling with a shrinking space in terms of what they could do and the threats against them, as well as the lack of resources, as well as intimidation as well. So Collective Voices for Health formed in 2022 in response, and that was when Dodula first started, blocking access to healthcare. They brought together 60 organizations, health workers, legal groups, community networks, and migrant-led structures, as well as researchers, on the basic premise of challenging exclusion, monitoring incidents, linking in with XenoWatch and other organizations, providing solidarity support. So when there's reports of clinics being blocked, actually having a visible presence and going there. And I think that's one of the key things that has been missing, is being able to respond directly in a crisis. And then we Collective Voice for Health sort of went quiet for a little while, and then was reactivated in 2025 again because of this increased activity by Dodula. And the key interventions generally have been the monitoring of health xenophobia, as I've said, linking in with XenoWatch and others, building coordinated networks. We also commissioned research that I conducted with a colleague, Irian Fremantle, to look at 20 years of civil society resistance and to document, what has worked, what hasn't. Looking at media and narrative change strategies, looking at sort of strategic litigation. And what we've seen in terms of, what has worked and what hasn't worked is, in terms of what works, is this deep legitimacy that comes from civil society for having been engaged for decades in this work. being able to mobilize quickly, respond, and build solidarity across communities. And I think key to, and sort of at the center of all of that is that many of these organizations and movements understand that organizations like Operation Dodula don't just emerge from nowhere. They don't come out of a vacuum, and they're not simply about xenophobia, but it's an anger that's rooted in long histories of dispossession, unemployment, poor housing, and other broken promises of democracy. So that's not an excuse for what they're doing, but it helps understand and possibly see points of convergence that, you know, Dodula members, for example, suffer the same system that exploits and excludes Black to come together. There is a very small sort of team that I guess formed Collective Voices and sort of meet regularly, as well as a much larger group on WhatsApp where we share information. And, you know, we've had a few webinars now where we've discussed strategies and ways forward. And, you know, particular things around documenting all these different cases that are happening. We've also, you can move the slides forward, by the way. We've also in the process of developing a leaflet that can be shared amongst migrants and within the health system facilities to reinforce what the rights are in terms of accessing healthcare. This example on the slide is a leaflet we brought out which contextualized the Section 27 case, which was particularly for healthcare providers because we realized many of them weren't aware of who was entitled to what rights. You can move on. I'm almost done, Joe. I know I've run out of time probably. And you can move on again, sorry. Yeah, so I've talked about what's worked in terms of our strategies. Obviously, it's going on. We don't have funding, so this is very much dependent on people being willing to sort of step up and be involved. There is a lot of state resistance. There's a lot of fragmentation and mistrust amongst organizations, which has obviously come out of and been exacerbated by the funding cuts as well. And there's a lot of fear as well, which we've seen particularly with how Operation Dodula targeted Seri when they challenged, you know, challenged them in court for their actions. But what we also saw was this incredible countermarch, which Operation Dodula did not expect, where lots of different organizations, both South African and migrant-led organizations, came together and, you know, stood in support of SERI, which is the Social Economic Research Institute. So speaking out is important, and you know what we've realized is it's important to be vocal, but to be strategic, and one of the key things, and I'm going to end here, is around not amplifying the voices of vigilante groups for no reason. So we need to be careful about sort of strategies, not making it just about Dodula, but actually make it's about the more broader structural issues and the current crisis that South Africa is in, with the government denial of, you know, where the health system is at, and where you know, corruption and the pocketing of money has gone in terms of the health system in particular. And it's about balancing long-term movement building with immediate crisis response, which right now is around ensuring access to life-saving medication and resisting obstruction of facilities. And framing this crisis as a shared struggle, as I said before. Migrant precarity mirrors wider inequalities, and defending constitutional values requires a coordinated response. So this is just the report that was written, which you can find online. And then if you want to go on to the next slide, this was one of the findings of the report, which was that there have been no big wins against xenophobia, including health xenophobia, yet there are numerous actors at different levels who continuously put out little fires in ways that are rarely publicized but constitute a key pillar of protection. These interventions fulfill the important function of someone showing up, of being there, and of holding space. And that's really, you know, what the mandate of Collective Voices for Health Access is to kind of show up, be there, and listen to one another. And I think that's also the rest of my slides are basically just illustrating some of the outputs from Collective Voices for Health Access, which I'm sure Joe will share the slides and make all of these available. There's also a list of resources at the end. So I'm going to end there. Sorry it was very rushed, but hopefully it's given you some idea about the work of Collective Voices for Health Access, and obviously I'm happy to chat and answer any questions about that further.
Thank you so much, Becky. And it wasn't too rushed, and you managed to get an awful lot there for us, a lot of food for thought. And yes, we'll be sharing all of the slides, including Diego's input, as well as the recording. So lots of time for people to spend. We'll add in links to all of the documents you've referred to. So we're now going to move to the final input from Federica Duca, who is here reflecting on some of the insights from the Johannesburg Crisis Working Group. Thanks so much, Federica, and over to you.
Thank you. Thank you very much. As Joe mentioned, I'm just going to reflect briefly on the work on a seminar series that has been ongoing for the last year and a half, which was titled A Multidisciplinary Approach to the Study of Urban Crises, a focus on the city of Johannesburg. So the seminar series was conceptualized in collaboration between the WITS, Concerned Academics, the School of Social Sciences, GCRO, SWAP, and PARI. And what we did over these 1 year and a half is that we've provided a collaborative space and dialogue with scholars, researchers, activists, and policymakers to share their ongoing work on the city of Johannesburg. So basically, what I'd like to discuss here very briefly is like some of the themes that we touched on and what this might mean for, how these can help us also understand the health crisis and the migration crisis in Johannesburg. But before I go into that, and also as part of the series, I'd like to give a few figures of context. Can you move to the next? Yes. From the Quality of Life survey done by the GCRO, where basically we see in the last years that, the overall context in Gauteng is quite dire. So high level of residents are using public facilities in terms of health. And I mean, this is a 66% now, as opposed to 62, I think, 4 or 5 years ago. So there's like an increase in using of public facilities. There's also an increase in risk of depression. More people think that crime got worse over the last year. Increasingly, more children in households rely on a school feeding scheme, and there's a very high dissatisfaction with government, higher, compared to previous years. So this is just to say that we're working within a context that is highly strained and strung, and where like all of these issues are compounding more and more. So we're facing basically what came up from the series, which is somehow not such a surprise, but it was very interesting to dissect all of these crises. Is that we experience a set of intersecting crises in the city. We've got water crisis, electricity crisis, safety and security, labor, housing. So we discussed how, for instance, water, access to water is not only uneven in terms of where the water cuts us, how people can make plans to have water when there's water cuts, but also what institutions and how existing institutions can do to the crisis. And interestingly, also what came up in particular ways is this the speciality of these crises, as is seen in the city of Johannesburg. So, for instance, as all of these crises that we have, the water, the electricity, safety and security, labor, housing, obviously we see them much more in spaces like the inner city, spaces like some of the outer areas, or the informal settlement. And these are also places where access to health and healthcare facilities, as it's been discussed and presented in this previous presentation, actually becomes more difficult to have. So we've got a greater compounding crisis. So the health crisis and the migration, xenophobia, etc., is compounded by all of these different intersecting crises in very specific spaces of the city. So, and these water, electricity, safety, and security exacerbate even more issues that we might have, for instance, in a clinic where access is denied to some people. And importantly, what was discussed was what institutions and existing institutions can do to the crisis, and to what extent, formal official institutions are part of the crisis. So, for instance, when talking about water, or when talking about electricity, discussions were drawn to questions of, do the existing framework that we have at a local and national level work? Or when we were talking about safety and security and accountability, questions were around, do we need the police? Do the police as an institution work to the effect that, to the constitutional mandate, or do we need to rethink and reimagine different kinds of institutions in these spaces? Like the labor crisis and, new, domestic work and sort of like labor in new outlets, and, how those deny some of the basic labor rights. And for instance, how do institutions respond to the ways in which residents or citizens act or respond to the crisis? So if there's no water or there's no electricity, there's a tendency to go off the grid. And this happens, well, in sort of like informal poor areas and in wealthy suburbs, obviously in different ways. But both practices challenge somehow the current fiscal framework. And so how do we think and reimagine fiscal frameworks and institutional frameworks that actually can work positively towards a better city? And obviously, also the question of institutions and local government responds in different ways to off-the-grid experiences of suburbs, as opposed to off-the-grid experiences in informal settlement or in the inner city. This is all obviously, all of these crises are to be contextualized in a broader and more structural institutional setup, which in Johannesburg can be characterized and described as of, local government of instability somewhat, to which the local government itself and a national government have been trying to respond with initiatives such as the bomb squad, the presidential intervention into the city of Johannesburg, which themselves have also posed some sort of like critical points with regards to how these interventions are executed, especially in the inner city or in informal settlement, where these seem to be more of like a war against the poor, or and highly characterized by xenophobic sort of initiatives. Can you move to the next slide? Yeah. So it seems that we are really, working within a multi-scalar governance fragmentation, basically, where we've got institutional instability, poor basic services that are, across the spectrum, obviously, but that manifest differently, obviously, in an inner city or in a wealthy suburb. There's high level of xenophobia and war against the poor. And also, this is all happening in an institutional context in which the city increasingly looks at its constituency as customers and not as citizens or residents having, equal rights to services. And I think this is a very important point that we need to take into consideration. So the city is responding to all of the crises, with some of whom it's also creating, by emphasizing the aspect of its constituency being customer, as opposed to a citizen or resident having equal rights. So you get a service if you pay. If you are in a space where the service, there's very little or lower rates collection, then there's more leverage to say, well, no, we're not coming there to fix your issues. To conclude, maybe not a provocation, but some food for thought. Obviously, it seems to me that with all of these intersecting crises, we are a little bit trapped in the paradigm of the service delivery, right? So we, as customers, we also as citizens, sort of like start thinking in the language of customers, right? And expect service delivery. And it would be maybe good to start thinking to moving from the service delivery paradigm to the right to the city one, which I know is not a new one, but might be quite helpful to take back somewhat. And that would allow, obviously, to move beyond a legal framing of citizenship, but also to move beyond the service delivery paradigm. I mean, which, as a final thought, there was a very interesting book by Zachary Levinson that was published a couple of years ago, looking at the housing crisis in Cape Town. And the title is Delivery as Dispossession. And the point that he was making was precisely that service delivery, conceived in the way in which it's been conceived institutionally now, actually always comes with dispossession. And this is because it works within this sort of like legal framework that almost by definition excludes who is not a customer or a citizen in the very, in the strict sense of citizenship. And perhaps it would be worth thinking how we can move beyond that paradigm to think of the intersecting crises, both at institutional level and obviously at the lived experience of residents of Johannesburg. Thanks. I hope I was on time.
You were perfectly on time, Federica, at exactly 11:17. So thank you very much for that. What we're going to do, we're running a bit later than we planned, but I think the inputs have been incredibly rich, and we're going to have a chance to continue this conversation through some future engagements. But what I'd like to do now is hand over to Lorena, who's going to give us some reflections and help us start pulling together the various inputs we've had. Thanks, Lorena. Over to you.
You can hear me, right? So, well, I think this is a really well-chosen set of presentations that give us a sense of the complexity of the issues at macro and micro levels. And I really appreciate this overview that Diego gave us about general trends, and then what it means for migration, internal migration, international migration, and how we can see, and then the examples of the more in-depth analysis focusing into main areas of the country, right? Concentration of migration, concentration of violence against migrants, and a compound crisis of the cities in Johannesburg, and what we observe also in the Western Cape in terms of the violence that emerges. And So, and on just for Diego, how important would be if we can move towards having disaggregated indicators, health indicators, to see really how actually counterproductive these exclusions are in terms of the well-being of the population as a whole. And we can see maybe the effect in the most vulnerable ones of these violence and restriction to access to healthcare in the health of children, for example. How health can this can ultimately affect the well-being of children, those who are born under those circumstances. And so an invitation to really disaggregate that in order to demonstrate the effect or the impact of it. I wanted to just briefly, I know I have 5 minutes, but to say that we were in this attempt to understand how migrants have a bigger effect on their health, and analysis of the causes of death that we did with death data exhibiting in stat SA, and showing how migrants tend to die more unnatural deaths than locals, and the maternity rates comparing local and foreign women was double than local women. These analyses are powerful because it shows the ultimate consequences. And I think Silindile, excellent work. I wish we could know a little bit more how these cases are reported and how then extensive access to reporting and inform bigger groups of population can make even a bigger impact in terms of understanding these causes and these events. For Rebecca, Becky, I think this is actually an example of how research can inform actions, right? And how they're bringing together what we know, the legal framework of this country, accessing them, giving access and giving voice to what civil society, informed civil society could do as active agents. Similarly to the example that Federica brought with concerned academics trying to do something to respond to the crisis of Johannesburg. So I think these are some different angles, something that is showing us the complexity and the multiple angles that we need to tackle here. I like very much the provocation of Federica in terms of how do we think about the city, and do we think about it and the government and the structures that we are challenging as a customer or as a citizen, and what is the language that are we using? But also, on the one hand, I suggested that we need to understand further and disaggregate the data of migrants to understand how the impact is felt in their and their children's well-being. On the other hand, I think that this understanding of the multi-layered crisis will require that we work reinforcing communities. And if there is anything that we can say in front of the Dudula intervention, it's like, we are scapegoating migrants, right? And we all know that. But how do we visualize these pervasive structures, or the misfunctioning or malfunctioning of structure that allow us to constitute communities that are not divided by nationalities, but concerned and interested and working closely. There, at that level, I think the difference between us and them should actually be in the mind of those who feel threatened by migration should be informed and enriched by analysis that bring us the complexity, but also the sense of these are the ones that we are attacking will not solve the problem that is somewhere in this multi-layered crisis. I don't know if I'm contributing to, but I thought that, yeah, I mean, I felt that from all these angles, there's so much that we can still do and should still do. Our research should actually feed into an understanding and intervention that we make from.
Thank you, Lorena, and I think you've done a very nice job in sort of pulling together these diverse but absolutely intersecting inputs through the lens of the city, thinking about multi-layered crises and the need to strengthen our interdisciplinary but also intersectoral approaches to the work that we're all involved in. So thank you for that. We are very close to time, so what I'm going to do is give all of our panelists a maximum of 1 minute to give one key reflection and take home message from today. And then we will be wrapping up, but as I said, there will be a platform for continued engagement. Diego, let me start with you.
Okay, thank you very much for those comments. I think what I would like to leave us with is twofold. Firstly, Statistics South Africa is currently in the process of reconceptualizing its household survey program, and the issue of disaggregation, not only by migratory status but between various themes, is a priority as a part of this. So that's something we will be working on. However, what I want to leave us with is that we're always talking about evidence-driven narratives, and we not really asking ourselves the question whether those we are in conflict with are driven by evidence themselves or not. Sometimes we feel or we notice that there are entities out there who are pushing a particular narrative that is in the public's eye very appealing, very attractive, but not based on science or based on evidence whatsoever, and intentionally so. And so I think that whilst putting out the right evidence and the right argument is important, it's maybe not the most effective way in trying to combat anti-migrant groups whose strategy is really about whipping up support and trying to push together a anti-migrant narrative at all costs. So really looking or suggesting that we look at hybrid approaches on how we can address these issues of systemic and intentional exclusion of migrants from services of the city. Thank you.
Thank you, Diego. So hybrid approaches, and those of us that work on evidence, a reminder to perhaps rethink some of our strategies. Silindile, if you want to give us a maximum of a 1 minute reflection from your side.
Thanks, Joe. I think it was really interesting to listen to the other presentations, and I think the discussions left me with more questions than answers. And I think it also underscored that there's still a lot of work to be done. I mean, some of us presented statistics in our presentations or discussions, but having been on the ground and having spoken to some of these migrants, you see that these people are beyond stats. It's real people whose lives are at stake. It's real people who have been traumatized by the process. And even though there's a lot of important and ongoing work that's taking place, to address this issue, but it's very urgent that we come up with solutions, because even as we speak, and I think Becky mentioned it, this issue is ongoing, and there are real life people whose lives and livelihoods are at stake as this continues on a daily basis. So I think there are no answers on my end, but I think it's left me with more reflections on how can we as a researcher or researchers play a role in addition to the work that we're doing, to contribute to addressing these issues. Thank you.
Great, thanks to Lindile. And as you say, a real reminder of the importance of statistics, but what are we doing when we're looking at real lived experiences on the ground, and what is our responsibility when we are working with those who are experiencing the challenges and resulting trauma that we've spoken to today. Thank you. Becky, over to you, your maximum of a minute.
Thanks, Joe. I'll try and talk really fast. I think what, all of these presentations and what Lorena have said here sort of, as Silindile said, it's raised a lot of questions, but I think looking at the work of collective voices, we see that when evidence is paired with coordinated action and solidarity, there is an opportunity for it to be a catalyst for change. For example, informing or educating healthcare workers in terms of what rights are and how actually blocking of clinics doesn't benefit anybody and actually is detrimental to health for all. I think this is one of the key things that research and evidence are essential in this moment, because that we're operating in an environment of denial and distortion, the Trump kind of climate. But rigorous evidence, can be a sort of foundation for the work of those who are on the front line. It can also expose the scale of exclusion, and be, it's not, research is not purely an academic exercise. It's a practical tool. It grounds advocacy, informs litigation. And I think, as I said, evidence also makes one point unambiguously clear, that no one benefits when clinics are blocked or children aren't able to access schools. Turning patients away doesn't reduce queues or increase medicines or improve staffing. It worsens care for everyone. And I think collective voices have realized that really pushing that narrative is where, we have an opportunity to actually hope for change. And it's hard saying that because I'm usually the cynic in the room, but I think it's really important to focus on, where those small little gaps are, and where we can actually really just keep pushing, because otherwise, I mean, I don't see where else we can go from here in terms of forcing change. And as Silindile said, these are real life-threatening emergencies for people in the moment. And so, just yesterday with Davidson Clinic was being blocked, immediately a message was sent to collective voices. Immediately there was, people organized to be there to document, but also to support. So I think those kind of actions that we see coming out of that collaboration are really important.
Great, thank you, Becky. So really a reminder about the need to have coordinated action, looking to catalysts for change and the ways in which evidence can be hopefully used in collaboration with civil society to look at improved experiences on the ground. Thank you. Federica, over to you for the final reflection.
Yeah, so thanks. I really like, I think it's very important what Diego mentioned about, providing evidence also to counter what is not based on evidence, which unfortunately it's quite dominant even in institutional discourses and in sort of like community meetings, in halls where ward councillors or the mayor, or like institutional figures are present. So I think it is really important to engage and to be present in those kind of sort of context and forums. And just maybe one reflection on how this and to what extent these challenges can reinforce community or can strengthen sort of like some counter mobilizing to experiences of denied access to clinics and things like that. And just out of my own experience, I see how in communities where there is like a higher number of migrants, it's extremely difficult to coordinate actions And this is not because obviously migrants do not want to be part of actions, but for obvious reasons of intimidation and all of that violence that we've been speaking about, and how that also then, sort of reshapes and somewhat pushes us to rethink really what community work can be in this kind of context.
Great, thank you so much, Federica. And I think that, this idea of strengthening counter mobilization speaks very well to what Becky was saying, links back to Silindile's point about the need for solutions at the local level. And I think all four of you, as well as Lorena, speaking to the challenges around, evidence, what kind of evidence and how to apply that. I think just to tie things together as we wrap up is, I think one of the key messages is that everyone is affected by these issues and that we are losing strategic opportunities if we only look at the experiences of, for example, international migrants. We know that internal migrants also experience these challenges, but the ways in which, for example, the police not responding to vigilante groups who are preventing access to services, that's indicative of the lack of policing, which is something that impacts everyone in the country. And the question I'll leave everyone with is, do we have a strategic opportunity, thinking through universal health coverage, thinking through the rollout of the national health insurance, and what does it mean when we are deliberately and explicitly excluding certain groups when we know we need to improve health for all in the country? So I'm going to leave it there and say a huge thanks to everyone, and we'll be sharing the recording and everything online. If you don't, please do follow ACMS. We now have a LinkedIn page, and we will be sharing everything. Now our website's been updated as well, so please follow those spaces for all of the updates. Thank you for coming. Thank you, everyone.